proximal portion was region, and then first you do the nearest IDAS for the LED, and then finally you put the stent here, like 28, and then LED looks like very much okay, and then you did the IDAS for the post LED and circumflex, and then finally the right coronary artery. And then for me, in my end, I have no issue for the LED circumflex, and just review together for the right coronary artery. So let me show. So this is how it looks like. Quite tortuous and big. And quite interesting for me because when I see this picture, actually this was significant, but angiographically not too much.
No, I totally agree.
Yeah. Okay, so let's open the IDAS. This is other case. Let's see. This is 6.6. And actually, I'm going to show like the series of the cases like this. And I think the issue of the sizing of the BBS is we should be on the same page. And I do agree this is probably too big. But I mean, how to analyze and which is like the borderline and which one is going to the randomized, which has to be excluded. I mean, I bring the series of the cases on the meeting. So, by the way, this case, you recall, starting from the proximal is big. So let's check the IDAS starting from here. And then our region of interest is somewhere like close to this side branch. So this is the IDAS picture, and you will catheterize disengage, which is good. So I can see the IDAS catheter into the outer. So go back to the ostium. Now I can see this is very nice ostial, almost no disease. Go distal. And still the artery is quite big. And then actually I try to analyze the artery because what we are looking by angio is lumen diameter, which was injured. By IDAS lumen diameter is of course corresponding to the angiographic diameter. So I analyze this lumen border, and then if I show you to the, this is like the minimum of the diameter, and this is the maximum of the diameter of the artery here. And then I can see the minimum is 3.9 millimeter, and the maximum is 4.1, and the mean lumen diameter is 4.0. This is how it looks like the size of the artery, and I do believe this is more accurate by IDAS than angio. And then I can see in the middle, this is quite interesting because angiographically not too much, but I can see the lumen is here and EM is here. So I do believe you agree this is a lot of plaque burden.
Yeah, it's lots of plaque burden, but as I said before, the reference diameter is so big. So in my mind, this is not suitable for BVS. So I just skipped it very, very early.
Okay.
Because there is a problem with overexpanded BVS. And so for me, I totally agree with you. This is possible, but I wouldn't dare to put in a BVS in this patient.
Yeah, okay. That's one I agree. But I bring some series of the cases, which is something like this. And then some of them is super obvious. It's huge. And this is, I think, a kind of the borderline artery. Like you decide not to delete, but the other possibly include. So those like the borderline vessel size, I bring some series, and then we can discuss all together, and then we are more comfortable not include or include on the same page. So we do at the meeting next week. But in terms of this case, I mean, you agree. So if you're going to analyze this portion, I can draw the lumen border is like this. And then in terms of the EM, I'd say I probably go to here.
Yeah.
So this is, go ahead. Go ahead.
Yeah, I agree.
Yeah.
I agree.
This is something like this. Yeah.
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 But the
Right
problem
now, I
is,
can get.
yeah.
Yeah.
One have learned over the historically what I have learned about BVS, that it has a tendency to recoil. So
Yeah, sure.
if I put in, and this is a problem with the very large vessel.
Sure. Yeah. Right now, I'm not going to argue you in terms of how to implement the BBS or not. And that I think I agree. But because of those of the cases, I can see many series of the cases like this. Obviously, that non-corrupted region there, and then somebody feel this is suitable, and somebody don't feel this is suitable. So that has to be make the more clear consensus for everybody.
Yeah.
So I think that.
I think it's important to discuss, especially because the 3.5, the largest BVS we have today, is 3.5. If I would have had a 4.0, all right, then I could have done it. But I just have the 3.5, so that's why I don't do it.
Yeah, I totally understand. So that portion, whether including the randomization or not, let's discuss next week with others. I think that we have to confirm each other. That's understandable. And in terms of this case, I mean, I think this case, I mean, in terms of the measurement standpoint, I believe this is very tricky cases because angiographically, almost like not very clear where the region is by angio, right?
No.
But if you go to the IBUS, you remember this tiny side
Yeah.
Yeah, and that is actually, I see here. So actually, the smallest area of the lumen is just distal to the side branch. So that's corresponding angiographically somewhere here. It's totally impossible to understand by angio. So let's assume this is the small artery, like which we can decide to putting the BBS. And then, like what we see by IBUS is somewhere here. So using this landmark, and then you should consider to put the BBS from somewhere here. So just like the as a regular IBUS interpretation, how to landing the stent without knowing the unclear angiographic stenosis, how to correct this time. I think this case is very important to understand. So this side branch, and this is a region, but unclear. But IBUS, you see this side branch is here, and then stenosis just distal to this. So to understand each other, in that point, I think this is important. Okay.
I can tell you another thing. After our last meeting, you recommended me start from the proximal and go distal, and I've started to do that. And everything it's much easier to interpret the IBUS after doing that.
Yeah,
definitely, it's much more easy.
Yeah.
Go ahead.
Okay, so this case, I think this is only one my issue. Like the LAD and circumflex was good, so I'm not saying any more for this case. And I moved to the 5. This case was actually I didn't mention anything when we feedback formally, but I will mention one thing because I see something. So just for you to remind. And this case is there is some angiographic intermediate region in the proximal right coronary artery, and also the main region as LAD, which is here, and then you wire.
I lost. Sorry, 5 seconds. Go ahead now. Continue.
Okay. So let's go. This is now you wire successfully. Now you see the entire LAD, and then after this you balloon. And then finally you put a stent, and then this close to the end of the picture is this one. So total occlusion, and then stent was implanted from here to here, right? So because of this was total occluded, I understand that this portion is still not very super big enough, but that's probably
No.
that's pretty much understandable. But I just want to show how it looks like the ibis. And just for the educational purpose, you may not recognize that time. So this is a picture after the stenting and in terms of the stented segment. So just keep in mind how it looks like the proximal edge and how it looks like especially the distal edge here. Okay, so now I'm opening the ibis corresponding to this picture. Okay, so now this is stent, and actually this was well expanded and very good job. And then let's go to the proximal. So this is the proximal side, and then we see some plaque, but that's fine. Lumen is good enough. And I would show just starting the proximal edge to the proximal side. So this is your stent edge. And then, can you recognize something here?
Yeah.
This is dissection. And actually, this is like the, I think that is reaching to the media. So like this, probably this picture is the best one, right? So how looks like the dissection if I draw exactly? The dissection flap is like this.
Yeah, I agree.
Right? Yeah, like this. The media dissection here, and then this is a flap. Right? Yeah, I mean, this is perfect. I don't think you need to treat this one because inside of the lumen is big. Actually, this should be here. This is big. So important to leave it alone dissection or not is how big the lumen. That's most important. And the second is how big the dissection. And this dissection for me is like 60 degrees. And even though you take it out to the wire and IDAS, this flap cannot occlude this artery. So including all together to leave it alone, this is fine. But yeah, just at least you have to recognize dissection is here. That's one thing.
Yeah, I totally agree with you.
Yeah,
I totally agree.
Then this case, I see one more thing. So go to the distal now. I'm talking now that this is the standard of the distal, and I go to the distal. So let's start from here, and what you see. This, okay, keep your mind somewhere here. And in my opinion, this is intramural hematoma. It's a little bit hard to recognize. I mean, when you see here, you can you understand somewhere here is like hyper intensity, and somewhere here is low intensity. This is not plaque, and this is actually intramural hematoma. And then I go to distal, and I see the dissection is it's hard, but I think the dissection is here. And this is a little bit hard to understand. So let me show some explanation. So what happens in terms of the intramural hematoma is like you make some dissection which reaching to the media. And then that dissection area extended to the longitudinally, and then the blood coming to that dissection space, and then you can keep the blood. And then this is going to the hematoma. And if we cut here, we can see the hematoma on the top, and we can see the lumen is here. And usually hematoma is pushing to the lumen, and then this is part of the dissection. And this is the most easy to understand IBUS picture, not your case, but you can see longitudinally, I can see the dissection blood is here, and then entry site is here, and blood is going to this side, and then blood accumulates. And because of this portion, the blood is stagnant. We can see the blood looks like very hyper intensity area.
Sorry, 5 seconds. 5 seconds. Sorry, go ahead. Sorry.
Yeah, so this is like the pushing to the lumen, right?
Mm-hmm.
And then usually when you see the hematoma, if you go to the proximal or distal side, you will see the entry side. So that is here.
Mm-hmm.
This is clearly media dissection like this, and then blood going to this way, and longitudinally going to this way, and then blood accumulating here. So the picture is like this. And this is a clear picture. It's very easy to understand by eyes. Your case is relatively unclear, but in my opinion, this is this medial dissection and intramural hematoma. Like where I see here, this portion, I don't think this is plaque. This is actually the hematoma.
Hematoma. You could be right. One thing which is important, your picture, the quality of the picture I see here is much better than the quality I see on my machine. This is much, much easier to recognize here. And I don't understand why, because the information is there without doubt, but it's so much easier to see it here.
I think one thing is actually what I feel is like the resolution of the IBUS picture is already decided, and we cannot change the resolution at all. And usually the picture in the cathedral is zoom out too much. Like I can see the picture like this, but when you see the picture in the cathedral, your size is like this, right? So if you expand too much with not enough resolution picture, sometimes the picture is even like looks worse. But I think those things
I
you
understand.
can.
I think the information you have here, I didn't do the case, I just saw the eyeless. And I totally agree with you, because this is a situation which is not uncommon. The picture you showed earlier, or the schematic drawing, this with the hematoma, that's a fairly common situation. And it's interesting, and it's also debatable, how long should I stent? I don't know. Should I cover the hematoma, or should I?
I think those things, still we don't have the super clear answer. But in my opinion, whether the entry point was covered or not, that's important. And the second is usually hematoma is going to stop if you have the branch or if you have the enough plaque, because hematoma is inside of the media. So if the artery is very diseased, the media is already scarring, it's very difficult to dissect. This is like the phenomenon of the aortic dissection. Like the old patient in the aortic dissection is usually DeBakey type 2 because they cannot extend too much because already scarring. But I think the most practical way is just waiting a little bit more, and then if flow looks okay, that's I think the most reasonable. And in terms of this case, I think because you have enough time, because you finished the LAD, now you are looking at the circumflex by IBUS, and then you are looking at the right coronary artery by IBUS. And if you recognize that hematoma before moving to the circumflex right, you just have to inject one more time after the IBUS pullback of the circumflex, just to confirm they look similar in terms of the angiographically, in terms of the flow. I mean, usually, if the hematoma is getting worse, they are getting worse very quickly. Like,
very quickly,
But
usually
if they are stable,
very,
And if they are stable, usually they are stable. So, like, just one more observation a little bit later, like 5 minutes, 10 minutes, I think that's probably the most useful, practical way to decide whether to do or not.
The most common situation, if I look back on my experience, the most common situation where I have problem is that the hematoma is going proximal. The distal hematoma, it's very rarely makes a problem for me, but the problem is with the hematoma going proximal, which happen, especially in the LAD, and then it runs into the left main and down into the circ, which creates a big problem.
I think that, yeah, I think, sure, that's very much common scenario. But
Yeah.
I think the key, which I would explain to you today, is because of the IVAS picture, it's sometimes not very easy to understand, sometimes because of the quality, but I can see the hematoma here. So just understand that it's there during the procedure. Will help in the future with knowing that's very clear.
Yeah, I totally agree. I totally agree.
Yeah, I think that's yeah.
Have you got my absorb case yet? Have you seen it?
No, we didn't receive yet.
No.
What is the number of the case?
It's the number is 7.
Okay, I see. Did you
So we have one. And we have sent it. I don't know where it is yet, but you will receive it very soon. I hope, because it's the first absorb case we have had so far.
I see. Okay. And so when did you do it?
I did it. It was last week or 1.5 weeks ago. It's
I see.
The 18th February, I think it was.
Okay, I see.
So it's last week.
Okay. Yeah. At least by now we didn't receive everything yet, but we will look into. And are you coming to the investigator meeting next week?
I'm coming.
Okay, sure. So we try our best to prepare by then.
Yeah, good.
Yeah. And then we discuss together in person.
Yeah, good.
Yeah.
Good.
Okay.
Do you have
Any
anything
other
more?
questions?
No?
Huh? In
Good.
my end, this is my feedback to you based on the new cases.
Yeah. Very good. Very good. I'm trying to learn and interpret and to teach my colleagues as well.
Yeah.
Yeah, good. Hopefully we do better.
Okay,
good.
Keep in touch.
Yeah.
Thank you so much.
Thank you. Thank you very much.
Okay.
See you next week. Yeah.
See you next week. Bye.
Yeah, bye.